Dystonia. Dystonia is a neurological hyperkinetic movement disorder syndrome in which sustained or repetitive muscle contractions result in twisting and repetitive movements or abnormal fixed postures. The movements may resemble a tremor. Dystonia is often intensified or exacerbated by physical activity, and symptoms may progress into adjacent muscles. The disorder may be hereditary or caused by other factors, such as birth-related or other physical trauma, infection, poisoning e.g. lead poisoning, or reaction to pharmaceutical drugs, particularly neuroleptics, or stress. Treatment must be highly customized to the needs of the individual and may include oral medications, chemodenervation, botulinum neurotoxin injections, physical therapy or other supportive therapies, and surgical procedures such as deep brain stimulation. Classification. There are multiple types of dystonia, and many diseases and conditions may cause dystonia. Dystonia is classified by is classified by clinical characteristics such as age of onset, body distribution, nature of the symptoms, and associated features such as additional movement disorders or neurological symptoms, and cause, which includes changes or damage to the nervous system and inheritance. Physicians use these classifications to guide diagnosis and treatment. Types: generalized, focal, segmental, psychogenic, acute dystonic reaction, vegetative vascular, generalized dystonias. For example, dystonia musculorum deformans Oppenheim, Flathead-Sterling syndrome, normal birth, history and milestones, autosomal dominant, childhood onset, starts in lower limbs and spreads upwards, also known as torsion dystonia or idiopathic torsion dystonia, old terminology, dystonia musculorum deformans. Focal dystonias. These most common dystonias are typically classified as follows. The combination of blepharospasmodic contractions and oromandibular dystonia is called cranial dystonia or Meiggs syndrome. Segmental dystonias. Segmental dystonias affect two adjoining parts of the body. Hemidystonia affects an arm and foot on one side of the body. Multifocal dystonia affects many different parts of the body. Generalized dystonia affects most of the body, frequently involving the legs and back. Genetic/primary. There is a group called myoclonic dystonia where some cases are hereditary and have been associated with a missense mutation in the dopamine D2 receptor. Some of these cases have responded well to alcohol. Other genes that have been associated with dystonia include CI zone, NAL, HETPONE-A3, and PRRT2. Another report has linked THA-PONE and SLC20-ETWO to dystonia. Signs and symptoms. Symptoms vary according to the kind of dystonia involved. In most cases, dystonia tends to lead to abnormal posturing, in particular on movement. Many sufferers have continuous pain, cramping, and relentless muscle spasms due to involuntary muscle movements. Other motor symptoms are possible, including lip smacking. Early symptoms may include loss of precision muscle coordination, sometimes first manifested in declining penmanship, frequent small injuries to the hands, and dropped items, cramping pain with sustained use, and trembling. Significant muscle pain and cramping may result from very minor exertions like holding a book and turning pages. It may become difficult to find a comfortable position for arms and legs with even the minor exertions associated with holding arms crossed, causing significant pain similar to restless leg syndrome. Affected persons may notice trembling in the diaphragm while breathing, or the need to place hands in pockets, under legs while sitting, or under pillows while sleeping to keep them still and to reduce pain. Trembling in the jaw may be felt and heard while lying down, and the constant movement to avoid pain may result in the grinding and wearing down of teeth or symptoms similar to temporomandibular joint disorder. The voice may crack frequently or become harsh, triggering frequent throat clearing. Swallowing can become difficult and accompanied by painful cramping. Electrical sensors EMG inserted into affected muscle groups, while painful, can provide a definitive diagnosis by showing pulsating nerve signals being transmitted to the muscles, even when they are at rest. The brain appears to signal portions of fibers within the affected muscle groups at a firing speed of about 10 Hz, causing them to pulsate, tremble, and contort. When called upon to perform an intentional activity, the muscles fatigue very quickly, and some portions of the muscle groups do not respond, causing weakness, while other portions over-respond or become rigid, causing micro tears under load. The symptoms worsen significantly with use, especially in the case of focal dystonia, and a mirror effect is often observed in other body parts. Use of the right hand may cause pain and cramping in that hand as well as in the other hand and legs that were not being used. Stress, anxiety, lack of sleep, sustained use, and cold temperatures can worsen symptoms. Direct symptoms may be accompanied by secondary effects of the continuous muscle and brain activity, including disturbed sleep patterns, exhaustion, mood swings, mental stress, difficulty concentrating, blurred vision, digestive problems, and short temper. People with dystonia may also become depressed and find great difficulty adapting their activities and livelihood to a progressing disability. Side effects from treatment and medications can also present challenges in normal activities. In some cases, symptoms may progress and then plateau for years, or stop progressing entirely. The progression may be delayed by treatment or adaptive lifestyle changes, while forced continued use may make symptoms progress more rapidly. In others, the symptoms may progress to total disability, making some of the more risky forms of treatment worth considering. In some cases with patients who already have dystonia, a subsequent traumatic injury or the effects of general anesthesia during an unrelated surgery can cause the symptoms to progress rapidly. An accurate diagnosis may be difficult because of the way the disorder manifests itself. Sufferers may be diagnosed as having similar and perhaps related disorders, including Parkinson's disease, essential tremor, carpal tunnel syndrome, temporomandibular joint disorder, Tourette's syndrome, conversion disorder, or other neuromuscular movement disorders. It has been found that the prevalence of dystonia is high in individuals with Huntington's disease, where the most common clinical presentations are internal shoulder rotation, sustained fist clenching, knee flexion, and foot inversion. Risk factors for increased dystonia in patients with Huntington's disease include long disease duration and use of antidopaminergic medication. Causes: treatment. Reducing the types of movements that trigger or worsen dystonic symptoms provides some relief, as does reducing stress, getting plenty of rest, moderate exercise, and relaxation techniques. Various treatments focus on sedating brain functions or blocking nerve communications with the muscles via drugs, neurosuppression, or denervation. All current treatments have negative side effects and risks. A gest antagonist is a physical gesture or position such as touching one's chin that temporarily interrupts dystonia. It is also known as a sensory trick. Patients may be aware of the presence of a gest antagonist that provides some relief. Therapy for dystonia can involve prosthetics that passively simulate the stimulation. Physical intervention. While research in the area of effectiveness of physical therapy intervention for dystonia remains weak, there is reason to believe that rehabilitation can benefit dystonia patients. Physical therapy can be utilized to manage changes in balance, mobility, and overall function that occur as a result of the disorder. A variety of treatment strategies can be employed to address the unique needs of each individual. Potential treatment interventions include splinting, therapeutic exercise, manual stretching, soft tissue and joint mobilization, postural training and bracing, neuromuscular electrical stimulation, constraint-induced movement therapy, activity and environmental modification, and gait training. A patient with dystonia may have significant challenges in activities of daily living ADL, an area especially suited for treatment by occupational therapy OT. An occupational therapist OT may perform needed upper extremity splinting, provide movement inhibitory techniques, train fine motor coordination, provide an assistive device, or teach alternative methods of activity performance to achieve a patient's goals for bathing, dressing, toileting, and other valued activities. Recent research has investigated further into the role of physiotherapy in the treatment of dystonia. A recent study showed that reducing psychological stress in conjunction with exercise is beneficial for reducing truncal dystonia in patients with Parkinson's disease. Another study emphasized progressive relaxation, isometric muscle endurance, dynamic strength, coordination balance, and body perception, seeing significant improvements to patients' quality of life after 4 weeks. Since the root of the problem is neurological, doctors have explored sensoromotor retraining activities to enable the brain to rewire itself and eliminate dystonic movements. The work of several doctors such as Nancy Beil and Joaquin Farias has shown that sensoromotor retraining activities and proprioceptive stimulation can induce neuroplasticity, making it possible for patients. Some focal dystonias have been proven treatable through movement retraining in the Taubman approach, particularly in the case of musicians. However, other focal dystonias may not respond and may even be made worse by this treatment. Due to the rare and variable nature of dystonia, research investigating the effectiveness of these treatments is limited. There is no gold standard for physiotherapy rehabilitation. To date, focal cervical dystonia has received the most research attention. However, study designs are poorly controlled and limited to small sample sizes. Medication, medication, surgery, jury, surgery, such as the denervation of selected muscles, may also provide some relief. However, the destruction of nerves in the limbs or brain is not reversible and should be considered only in the most extreme cases. Recently, the procedure of deep brain stimulation (DBS) has proven successful in a number of cases of severe generalized dystonia. DBS as treatment for medication-refractory dystonia, on the other hand, may increase the risk of suicide in patients. However, reference data of patients without DBS therapy are lacking. History. The Italian Bernardino Ramazzini provided one of the first descriptions of task-specific dystonia. In chapter Roman 2 of this book's Supplementum, Ramazzini noted that scribes and notaries may develop incessant movement of the hand, always in the same direction. A report from the British Civil Service also contained an early description of writer's cramp. In 1864, Solly coined the term scrivener's palsy for this affliction. These historical reports usually attributed the etiology of the motor abnormalities to overuse. Then, dystonia were reported in detail in 1911 when Hermann Oppenheim, Edward Flatow, and W. Ladislaw Sterling described some Jewish children affected by a syndrome that was retrospectively considered to represent familial cases of DY-tone dystonia. Some decades later, in 1975, the first international conference on dystonia was held in New York. It was then recognized that, in addition to severe generalized forms, the dystonia phenotype also encompasses poorly progressive focal and segmental cases with onset in adulthood, such as blepharospasm, torticollis, and writer's cramp. These forms were previously considered independent disorders and were mainly classified among neuroses. A modern definition of dystonia was worded some years later, in 1984. During the following years, it became evident that dystonia syndromes are numerous and diversified. New terminological descriptors, e.g., dystonia plus, heredogenerative dystonias, etc., and additional classification schemes were introduced. The clinical complexity of dystonia was then fully recognized.